Hey everyone, you're welcome to Senpai Mid Skills. Like and subscribe to my YouTube channel. And today we're going to talk about the cardiovascular diseases, and the first one we shall talk about in brief will be the acute coronary syndrome. Acute coronary syndrome, it refers to a condition brought on by sudden reduction or blockage in the blood flow to the heart. So it has a couple of conditions within it. That's why it's called a syndrome. And some of these traditional types that we have, the first one is unstable angina, and the other is ST segment elevation, myocardial infarction, and the last one is non-ST segment elevation, myocardial infarction. So these three make what we call the acute coronary syndrome. And the essentials of diagnosis of this syndrome, we have prolonged or more than 30 minutes chest pain associated with shortness of breath or dyspnea, nausea and left arm pain that normally associates also the neck, and also diaphoresis. Diaphoresis, it refers to extreme sweating, extreme sweating, unexplained sweating, and also it can be painless in diabetes. Then the other essential is S4, that is an extra extra heartbeat that is also altered. Then also S3, that is in mitral insufficiency on occasion. Then also cardiogenic shock, ventricular arrhythmias may complicate. Unrelenting chest pain, that means chest pain that does not yield. Unrelenting chest pain may mean ongoing jeopardized myocardium. So this unyielding chest pain may mean destruction of the myocardium, that is jeopardizing the myocardium. So let's go to the differential diagnosis that someone would think of in acute coronary syndrome. The first one is stable angina. It is a differential. You can think of aortic dissection. Aortic dissection, it is rupture of an aortic aneurysm. Aortic dissection is rupture of the aortic walls. Then the second one is Tietze syndrome. Tietze syndrome, this manifests with pain in the chest that comes as a result of costochondrial joint inflammation. And in this, we have cartilage in the joint between the ribs and the breastbone getting irritated. So that irritation of that cartilage between the breastbone and the ribs causes the pain, or causes what we call costochondritis. You get it? So when this manifests and the chest remains swollen even with the pain capsizing, that's what we call the Tietze syndrome. Then the third differential diagnosis is cervical or thoracic radiculopathy. This is at times called the pinched nerve. It's at times called the pinched nerve. How does it occur? It occurs as a result of irritation of the nerve in the neck, causing pain, numbness, or weakness radiating into the chest. So that's how the chest pain comes in. But it's a result of the irritation of the nerve. Then the other, we have esophageal spasm or reflux. This one in a layman's language, it can be called as heartburn. It also manifests with that chest pain, for it is burning in nature because of the reflux of the gastric contents. Then the other we have is pericarditis. Pericarditis is inflammation of the pericardium. Myocarditis, inflammation of the myocardium. And then we also have Takotsubo's cardiomyopathy. Takotsubo's cardiomyopathy is at times called the stress-induced cardiomyopathy. This one it normally affects it normally affects the people that are driven so much with emotions, the athletes. Yeah, and how it is defined as a temporary heart condition that develops in response to an intense emotional or physical condition. Yeah, so that can also be a differential. You can have the chest pain after doing a very strenuous activity like running. You can have chest pain as a result of an emotional experience. For example, you've had an heartbreak. In fact, this is also called a broken heart syndrome. Yeah, this Takotsubo's cardiomyopathy. It's also called broken heart syndrome. Then the last differential would be pneumococcal pneumonia and pneumothorax. Then treatment would involve stabilizing the patient. Because there is difficulty in breathing, would consider oxygen therapy. Yes, oxygen therapy and close monitoring of the patient. We can give aspirin. We can give blood thinners. We give aspirin. We can give heparin if it's not contraindicated. For example, in people with coagulopathies, we can consider giving clopidogrel. It's a very good blood thinner. Then also we can consider giving oral beta blockers. Then we also do reperfusion by thrombolysis. And it should be done early. Or we can also do percutaneous coronary intervention in selected patients. For this, it's also known as PCI. It is a minimally invasive procedure used to open clogged coronary arteries. So we can as well do that. And then the other attempt we can give nitroglycerin and morphine for the recurrent ischemic pain. It's also useful for relieving the pulmonary congestion. But in giving morphine, it being an opioid, we have also to closely monitor the patient, because morphine, one of its side effects can bring about is respiratory distress. So we give as we monitor and as we ensure that facilities are there for ventilation of the patient, adequate ventilation of the patient. Then we can also give an angiotensin converting enzyme inhibitor like captopril and enalapril. Those are the common ones you can get. Then also we can give an angiotensin 2 receptor blockers, all ARBs, for example, the losartan, the statins. Yeah. Then we can also give an aldosterone blocker such as eplerenone. The most common one also you can get in Uganda, you can have spirolactone, a non-selective aldosterone blocker or aldosterone receptor antagonist. So we give these ones to improve ventricular remodeling after the infarcts. In our next video, we shall have to share more about how these aldosterone receptor antagonists work. We shall go through into their deep pharmacology. How do they increase? How do they reduce the blood pressure of the patient? We shall look at their mode of action. And lastly, we have to ensure that we proceed rapidly to the reperfusion of the ST segment, in the ST segment elevation. As time equals the muscle, the more time we take without reperfusing the heart muscle, the more time we grant for these cardiomyocytes to do what? To die off. Thanks for listening. If you like this video, please subscribe, share, like, and let us catch up in the next video.